first. So everybody, welcome to Julia's Way. This is a breastfeeding support group for moms who have babies with Down syndrome or who may be pregnant with a baby with Down syndrome. Today, we opened the platform a little bit because we have such an amazing speaker that we allowed professionals and parents of children that are older with Down syndrome to attend as well. The only thing we ask is that when Dr. Boyd is finished speaking and answering questions, we will then get to the business of doing our Zoom call and support for breastfeeding moms. So we would ask everyone else to leave at that point. Just to introduce myself, I'm one of the co-moderators today. My name is Geschwint Rabin, and I am in the north suburbs of Chicago. I am a speech pathologist and board certified lactation consultant, and have been working with infants to 3-year-olds for almost 36 years. My passion is working with babies with Down syndrome, and I do lecture nationally and internationally on how to transition babies with Down syndrome to the breast. And Rachel, do you want to go ahead and introduce yourself?
Yes, thank you, Jill. My name is Rachel, and my daughter Anna is 2 years old, and she has Down syndrome and also had duodenal atresia. She was able to breastfeed after some challenges, so inspired me to try to help some other moms to breastfeed their babies with Down syndrome. So, and I'm in south of Boston, and I look forward to hearing Dr. Boyd's presentation. Thank you.
Awesome. So you are in for a very special treat because I'm going to say I'm fangirling here to have Dr. Boyd speaking with us, because this is a person who is changing the world with the work that he does. He is a pediatric dentist in Chicago, and he is focused on sleep and airway. He's involved in all types of little research projects all over the country. He is the author of something called Darwinian Dentistry. I encourage you to read it. It's incredibly informative. He has a nutrition background. This is a guy who knows so much, and he knows so much in terms of how he can help babies with Down syndrome. And I'm really hoping today that you'll understand the importance of the work that he does and why it is important for you, if you have a child with Down syndrome, or if you work with children with Down syndrome, to see a dentist like this who really understands how the structure of your face is going to impact your airway and your sleep. Kevin, did I miss anything important?
No, that's very generous. Thank you. I'm honored to be here. You're a very elite group. You've got a great reputation, and yeah, glad to work with you guys. So let me know. You want me to start her out?
Sure, you can get going.
Okay, well, I'm briefly chatting with Rachel and Jill beforehand. I'd let them know I'm a big Beatle fan, and if anyone else is a Beatle fan, you'll know the significance of the name Julia. I'm what I say is meaningless, but I say it just to reach you, Julia. So it's more than a name. She was the biggest inspiration, and ultimately he formed the Beatles, but she came up with lots of sayings, and one of them was, John, why wouldn't you do that? Like, Mom, I'm going to call Grandma on her birthday. Well, why wouldn't you do that? And he came up with this: as breathing is my life, to stop I dare not dare. Julia inspired that, and this hangs in my office. And I just thought, wow, this is like, I enjoyed putting together that little scenario there for you. So anyway, I'm going to talk about something called the craniofacial respiratory complex. In medicine and dentistry, we're taught about the cranial, meaning the cranium, and facial complex as being one thing, and it's because they're interconnected. The cranium is where your brain grows, and your brain grows your skull to its full potential. In the face is below that, and it's like, how do you grow that? Doesn't it just grow normally? It's the tongue. The tongue grows the face. You know the soft spots on your baby's head, the fontanelles? You got those all over your face and your palate. And you don't have the brain just automatically grows and the skull expands. Well, as an anthropologist, I know that throughout human history, babies were breastfed into the 3rd year of life for over, are you ready for this? 300,000 years. If you have a problem with that, get over it, because it's true. That's how long we've been around. This genome has been around. And the tongue, breastfeeding, ancestral patterns of breastfeeding and baby-led weaning is what made it so there never needed to be an orthodontist till about 400 years ago. So we go 300,000 years not needing an orthodontist, and then bingo. So, okay, so that's not genetic, it's epigenetic. So what Jill, Rachel, and everyone's doing is encouraging and creating competence in breastfeeding. That's the way it should be for every mother on the planet. So this is something that I've developed. I hired a medical illustrator who's an otolaryngologist through this and gave me permission to use it. The back of the face is the airway. The front of the airway is the face. I've been doing this long enough that I can, and many of my colleagues, we can read a face, we can look at a face, and, you know, as if we were Clark Kent from Planet Krypton, we know what the x-ray is going to tell us. We need the x-ray to verify it, but not always. So anyway, it's very important to connect this. Now, this is a term I want people to really sort of get out of their mind, macroglossia. Kids with Down syndrome have macroglossia. Their tongues are too big. Well, I wear a size 8 shoe. And if you buy me a size 5 shoe for Christmas and you tell me my feet are too big when I can't get into it, I'm sorry, thanks for the gift, but you gave me the wrong size. So if a jaw and face, we call it maxillary hypoplasia, that the face is too far back and the jaw is too narrow, that's like, you know, it isn't that the tongue is too big, you know, the place where it's supposed to live. And what I say is a tongue beginning in utero is responsible for building a home for itself to live in for the rest of its life. So when babies start chewing amniotic fluid in utero, that's what starts to develop the palate and facial sutural complex, just like the cranium. That's how it works. And weaning onto hard and firm under-processed foods, that's what takes it all the way. And then a lifetime commitment to eating fresh, hard, firm, fiber food and breathing clean air. That's what assured that it lasts a whole life. And that's what our ancestor did. They didn't live much past 30, but you know what? They died with full jaws and faces and wisdom teeth fully in. Who knew that? I didn't learn that in dental school. When I first found out about this, I got angry. Why did they teach me this in dental school? So this is just wonderful that moms of kids with Down syndrome and other, you know, problems that make it difficult, you can develop the competence just as much as anybody else. It may take a little longer, but so what? Nobody's going to give up on you. And that's what I tell parents. Oh, I was told my kid's too young to have expanders. Wait till they have more permanent teeth. Are you kidding me? You know, would an ophthalmologist wait till a kid is driving a car to correct their 4-year-old's nearsightedness? That can cause cognitive problems. It can cause behavioral problems. Kids need to be encouraged to have maximum tongue space at the earliest possible age, regardless of Down syndrome or not. Every kid on the planet deserves to have this done. But unfortunately, there ain't a ton of people like Jill and Rachel. And you know what? I'm part of a large group of pediatric dentists, orthodontists, general dentists that see kids, and healthcare professionals, myofunctional therapists. But these are, again, it's called maxillary hypoplasia, and they will call it other things. You know, they'll say micronathia, or it's just another word for maxillary hypoplasia. So I won't belabor that, but it's real important as we start this. Tongue tie is another thing. A kid who has some degree of tongue tie, and not every health professional, oh, that's not a tongue tie. It's got to be tied to, you know, so they can't get it out of their mouth. Nonsense. Kids can get their tongue out of their mouth, but and then straight out like a diving board, it goes down like that. That's a posterior tongue tie. And it can prevent a child's tongue from building its nest. A tongue is responsible for building a nest for itself. And breastfeeding is one thing that is a really strong component. Before I met Jill and before I really understood all the implications with Down syndrome, I was always a proponent of breastfeeding because I have a master's degree in nutritional biochemistry from Michigan State. And infant nutrition was something that I was very much interested in early on, even before I knew I wanted to be a dentist. If a kid has a tongue tie, they will need to see a myofunctional therapist to confirm the assessment or diagnosis, and do exercises. It's like prehab. Like I had ACL repair. I had to do physical therapy beforehand. They call it prehab, and then I had rehab. You establish those patterns in the kids' neurons, and you need a myofunctional therapist. So this is Jody Walker. She's my myofunctional therapist. If I can get this out of the way, I want you to hear her talk.
Hi, my name is Jody Walker. I am a speech pathologist and a myofunctional therapist. And Dr. Boyd has asked me to say a couple of words about the importance of myofunctional therapy as part of an overall airway health program for all kids, for kids of all backgrounds. I've been working as a myofunctional therapist for about 12 years and have had so much success with kids of all different neurological backgrounds, with Down syndrome, with autism, with cerebral palsy. And I am convinced that with the proper developmental techniques, food-based, play-based activities, and most importantly, strong relationship between the therapist and the child, that kids of all backgrounds can learn how to rest their tongue on the roof of the mouth, how to keep their lips closed and breathe through the nose, and develop the skills, the tone they need to be able to enjoy their food and properly manage it. As we know, the skull is a dynamic, living being, right? Part of our dynamic living selves, and our tongues are crucial in helping that skull to grow properly and to be able to be the pathway, the stable pathway through which all kinds of energy moves up and down from our brain to our body. And the tongue resting on the roof of the mouth, again, provides that little bit of pressure that's needed to keep everything wide forward and to make lots of space for breathing. So I am here to say every kid has a right to a full breath, and every kid can learn with the proper techniques how to rest the tongue and breathe through that nose. Thank you.
So Jody's great. She comes to my office once a week and she's 7 miles away. A lot of people go to her. I have lots of myofunctional therapists, luckily in Chicago, that we mutually refer to and take care of. We collaborate on children.
So, Kevin, one thing I would say, so with oral facial myology, usually we recommend 4 and up. They work with an oral facial myologist because then it's more voluntary. You're not supposed to do oral facial myology, so to say, until kids are 4 and they can actually imitate and participate and understand what they're doing. So 4 and under, speech pathologists, we still do that. So I do that with 0 to 3. I do a lot of the same things they do, but tailored to babies, and it's more us doing it to the child than them necessarily imitating and doing what we're doing. So I just wanted to clarify that.
Who's talking? Who said that?
That was Jill, the speech
Jill.
pathologist.
Oh my God, another reason to love you. I have had such run-ins with myofunctional therapists that don't want to see them till 4. And I'm like, man, that's so awesome. Thanks for telling me that.
So it is important that anybody who has a child with Down syndrome is working with a speech pathologist who knows how to do what's called neuromuscular reeducation to do these exercises to help. So we can talk about that afterwards, but I just wanted to bring that up.
All right, so here's an article that, again, they took one child and these engineers devised this whole model for studying apnea on kids with Down syndrome, utilizing synthetic materials that imitated nature. And this is like amazing how they did this, because these are similar to the drawings that I use and some I just showed you. Is that, all right, so, here's the palate, here's the adenoids, this is the constricted airway right here, here's the base of the tongue. And they had these materials, and you'll see in some of the stuff that I'm going to show you how if the tongue and the soft palate, all right, if the base of the tongue is pushed back because the jaw is too far back, that's where it lives, in the lower jaw, the mandible, and this lives on the back of the hard palate. If these, if the upper jaw is hypoplastic or midface deficient, if the lower jaw is retrognathic or chinless, as a derogatory term, it'll push right into the posterior throat, and then that's where the adenoid lives, and it can just totally cut off an airway. There's other reasons why airways get crowded. Adenoids always get the blame for it, but again, if the upper jaw is too far back, it'll push the soft palate into the back of the throat. If the lower jaw is too far back, it will push the base of the tongue to the back of the throat. If a kid is overweight, and a lot of kids with Down syndrome and other kids, it's childhood overweight and obesity is a big, huge problem in industrialized nations. They can accumulate fat in their tongues, in their soft palates, and on the throat walls. So that's another different issue that we have to take care of.
Okay. Hi, my name is Don Hubert.
I'm Samantha Hubert. I'm Annie Hubert.
And I'm Jessica Hubert.
And we were put in touch with Dr. Boyd about a year and a half ago. We had seen 2 or 3 dentists prior to Dr. Boyd, and they kept on telling us to wait until Natalie got older. We thought there was something more that we could do. And when we saw Dr. Boyd, he had a plan. And we got an expander in Natalie, and you've been wearing it now for about a year and a half.
His office has been very patient. It took us about 4 months of working with her and taking her down every month to see to Dr. Boyd's office, and finally she has it in. Now it's a routine, no big deal. Puts it in every day, and it's been fantastic.
So yeah, the staff, along with Dr. Boyd, has been very, very good with us and with Natalie.
And we're happy with the plan he has in place to help fix her mouth and her teeth and her airways, because we know that that's extremely important with our kids.
So yeah, so we've had a very good experience so far, and we hope that keeps on going, which we're sure that it will.
So that
Thank
is
you.
not meant, hello, that's not meant to be self-promotional. This is something that you as moms and dads and parents of these kids, you should demand this, that you get this kind of support from your dentist and collaborating with your pediatrician and myofunctional therapist. That's not an unrealistic expectation, but if you don't come in there and expecting it, this might not, and you're not going to see it, that might not be the right office for you. And I say anybody listening to this, do your best to work with your existing dentist and let them know that, would you please consider expansion for my child? And guess what? Your kid needs expansion. If your child has Down syndrome, your kid has hypoplastic challenges that can be resolved early on and could make a difference in their neurocognitive, neurobehavior, even cardiac health long-term. Quality of life for the whole family can be affected by this. There's papers written on this, not just with Down syndrome, but maxillary hypoplasia per se. When you expand a kid, you improve everybody's quality of life. So why they were told, wait, and remember the analogy between ophthalmology. And I showed this last night for over 3 hours to people all over the world that were listening to, and I wasn't talking about Down syndrome, I was talking about maxillary hypoplasia, which happens to be a strong characteristic of kids with Down syndrome. Well, I showed this, you wouldn't second guess, if a ophthalmologist said to you, he's too young for glasses, you'd find another ophthalmologist. Well, if you're being told by a family dentist, a pediatric dentist, or orthodontist that they're too young, your children are too young, or maybe they're just not able to comprehend and cooperate, you know what? That's not the right office for you, but try to help them along first. If I had time, I would show you results that would knock your socks off of kids we've helped. But look at this. This is for a 2-year-old. We expand 2-year-olds. And again, why not? Preschoolers should be getting orthodontics. Any kid, first-year dental student can look at a 3-year-old and say, save up your money for braces, because certain types of hypoplasia in the jaws, it will persist reliably beyond, and it will worsen, and it will at some point probably become what we call a comorbidity, or associated with sleep and breathing issues, which can contribute to neurocognitive and neurobehavioral issues. Even height. I always get little boys to where you want to stay that height all your life, you'll get taller if you're breathing better while you're asleep. And it's true. So I'm bringing this up not to indict orthodontists, but they say by age 7, maybe it's okay. I say a 7-year-old is a geriatric patient in my practice. I want to see these kids way before that. And most orthodontists really don't start seeing kids till about 13. Well, how come? Because in their training, they learn, boy, we do not begin treating, until a patient has their permanent molars in. And the biggest reason is cooperation. Often a 3 or 4-year-old patient simply is not capable of understanding what is required. Now, are you kidding me? If somebody said that, well, your kid's not capable of, because of their age or because of some genetic issue with them, they're not capable. You know what? Kids of all stripes are programmed. I'm an anthropologist, remember, are programmed to want to be obedient. When they see it's important. I had a mom in the other day, oh, he'll never wear a retainer. And the kid was wearing glasses and a COVID mask. And I said, are you kidding me? Why do you think he's wearing glasses and a mask? Because you think it's important. When children perceive that their parents think it's important, they will do this. And parents get confidence when they talk to me and my team. They know, they can hear it in our voice, they see it, and we show them results. We can do this for your child.
Okay, this is a mom who's convinced that, even though he's combative and has some special
I'm going to
needs,
turn the sound off.
this is in his best health interest to do this. So he's angry and he's a little scared, and this is new, but we know this is going to help him. So we're going to stay the course. So it's maybe disturbing for some people to watch, but okay, let's go. Let's put it in, big handsome man. Oh, I'm sorry. Okay. What you do is you put your index finger in the rectal molar area. And then you can't really bite you, even though he would love to. Okay, more cement there, please. Please. More cement there, please. Right now, more. Good job, Carmina. Right, Carmina. Move on this side. Okay, you got it. Okay, now that's it. Okay, that's good. You want to?
Okay, so here he is.
Can you show me? Where's your expander?
That was like
Look
a,
up.
that was.
And there's no owies?
No alleys.
Okay, say bye, Dr. Boyd.
Hi, Dr. Boyd. I will see you.
So, he when he got up from the chair after he got that thing in, he was walking out and playing with toys, and we have a service dog there who's playing with Blue. They're not traumatized. I mean, it traumatizes us. It doesn't me anymore because I know it's helping them and I know they get over it. So anyway, quality of life, even, just expanding a hypoplastic maxilla can impact bedwetting, conductive hearing loss. How about that? Obstructive sleep apnea. This is a really interesting situation, but there's lots of articles about conductive hearing loss in kids who have narrow jaws and, Down syndrome or not. And this is a mom.
Hello, my name is Janet Castillo. This is Julian. Julian is 10 years old. He is diagnosed with Down syndrome along with some other medical conditions. We found Dr. Boyd through Dr. Lavmani. We came here 3 years ago.
He's a sleep doctor.
Asking for help to improve his breathing after a few surgeries with no success to help with severe sleep apnea. Dr. Boyd and staff have been a blessing to our family. Not just his breathing got better, but also his hearing got better. His hearing improved tremendously. Julian is now sleeping better, sleeping all night, and he's also hearing better. His speech has improved tremendously thanks to his hearing. We are so grateful for Dr. Boyd and staff. We just want to say thank you. Thank you, Dr. Boyd. Thank you, Danny. Thank you, Ola. Thank you, everyone in the team. We're just very grateful. Right, Julian? You want to say thank you.
Thank you.
Thank you.
Yeah. So this is really an amazing story. She was told that he has congenital hearing loss. It's not conductive and that it's permanent and he'll never hear. And he didn't talk. And after the expansion was done, he had a hearing test and they were calling people into the lab to see this. And he is talking now. So we're going to study this kid. We don't know how it works, but it's an amazing story. Anyway, what we do is we widen the jaws and we advance the jaws. Now you can move your lower jaw forward. Anybody can stretch their lower jaw forward, but you can't stretch your upper jaw forward. But guess what? Your upper jaw can be stretched forward. If you do it, oh my God, who's doing it? I have the Woody Woodpecker ringtones. My staff did that for me. Anyway, if you do this before 8 years old, you can actually not only widen a kid's jaw across the palatal suture, but you can bring the entire upper jaw forward. And it really is associated with better breathing, and it really resolves the hypoplasia. This is how we do it non-surgically, and this is what Julian got. He had an expander in top and bottom, and he wears this little mask at night that helps his upper jaw grow forward while he sleeps with rubber bands. Okay, and this was shown at University of Michigan, how the entire jaw comes forward. And I'll show you how that works. I did a little sort of Photoshop rendition. So that's what happens. And that this part of the back of the jaw brings the saw palate forward away from the adenoids. So there's you can do this. Like I said, I do, as long as there's 20 teeth by 2.5 years old, I will do this. And it's been done for 100 years. I have medical and dental literature from over 100 years ago. Physicians and orthodontists and dentists were doing this before the turn of the last century. And then World War II happened and they stopped doing it. But we sort of, and other groups that I'm in are bringing it back. This is a paper, an editorial, guest editorial I wrote for an infant nutrition journal. And this graph shows, and we'll send you copies of this, how as the duration of breastfeeding goes on, the incidence of my hypoplasia goes down. And there's lots of articles like this, but I just put this one in because I wrote it. So anyway, there it is. You can see that. And there's the reference for it. And I'll send copies of any of these papers.
Have revealed how babies breastfeed. It was previously thought that babies use a compression motion of the nipple to push milk out. But the new images show that babies extract milk by lowering their...
Okay, so here's what's happening here. The tongue is pushing the mom's nipple against the mid palate up in the roof of the mouth and forward to here, okay? So when a baby breastfeeds, it isn't just massaging the milk out. There's actually a vacuum created, and the front of the tongue pounds against this little fontanelle. It's like a soft spot on the skull, and it comes all the way up to above the nose. It advances, not only widens the jaw, but pushes the whole front of the face forward. Remember what I said, the tongue is responsible for building a home for itself to live in for the rest of its life. And this all occurs from mid-gestation all the way up to about 7 years old, when the tongue really stops growing. It doesn't really have a whole lot of growth yet, but it's still, by then, usually by 8 or 9 years old, I want these dimensions to be the adult size. And often they are. We measure them at these baby molars, and we've got all kinds of metrics we use to validate it. So here are the sutures that get pushed, and nursing does it, and weaning onto hard, minimally processed fresh foods does it. A lot of kids have sleep problems. Should all kids have a sleep test? And there's some controversy about this. And I was Dr. Lockmanny who referred that last patient to me with the hearing problems. If we get invited back, he and I will do a joint, because we've done research together for over 12 years. He refers a lot of kids to me, and to work in concert with him, the otolaryngologist. So he doesn't necessarily agree everybody should have an in-lab sleep test. Now they have sleep study. This is, it's a big burden for a child to do, and it can be scary. So we want to, unless it's a dedicated pediatric sleep lab that is real kid friendly, It's really reserved that as a last resort. Home sleep tests were part of a study that we're testing this on children now to do home sleep studies at home. We'll keep you posted, but as of now, we don't have enough data. But this can be really scary setup. This is a kid-friendly sleep lab in a hospital, but it's better when we can do this in their own home. And that's coming, and it's already starting in some places. So that's it. That's all I got. Sorry if I took too much time. We got a little late start though.
Hi, Kevin. It's Jill again. And we've got some questions. That was absolutely outstanding. I think
Oh.
the important thing to know too is remember that children with Down syndrome lower muscle tone. They tend to be mouth breathers, and just like Dr. Boyd said about that small, everyone thinks that children with Down syndrome have bigger tongues. No, they just have a smaller oral cavity. So doing these things so what I do as a speech pathologist very early on is working with moms, getting them to breastfeed so that tongue can help expand the palate, working on a closed mouth resting posture, tummy time. All this preliminary work is going to help, and then getting to solids and eating real foods is also going to continue that help. But Dr. Boyd, some good questions. Somebody asked, what is the appropriate age to start expansion?
Okay, the appropriate age, again, there's a cultural aspect to this. And, whether a kid has challenges, it doesn't even matter. Every child, for me, that has hypoplasia, maxillary hypoplasia, which usually means lower jaw hypoplasia as well, meaning just undergrowth. Any child in the under the age of 6 is a special needs child, because to date, they're pretty much being ignored by the orthodontic. I mean, there's cleft palate and things. There's a lot of orthodontists that do a lot of great things for kids, but to just expand a kid whose jaw isn't wide enough or isn't forward enough, oh, that can wait till they're older. That's just cosmetic, and don't really tend to acknowledge and give recognition to, if there's not room for the tongue, then the airway can be literally impacted. And if the airway is impacted, the brain can be literally affected. They can, the neurocognitive and behavioral problems are associated with lack of full delivery of oxygen while you're awake and asleep through the nose. It's scary, and how much literature there is out there. So I say the right time is when the parents are motivated. You wouldn't say, when's the right time to put a pandemic mask on my child? We're not leaving the house. If you're a parent and you think your kid isn't ready to wear a mask, then please don't take them outdoors. But you know what? If you want to improve your child's quality of life and your family quality of life, let the child know that the mask is important. That kid will do it. They're hardwired to want to be obedient. Ask any cultural anthropologist. This has been known for decades. So the right age, biologically, is when they have 20 teeth. That's when you can do it. The window of opportunity is open then. But I like to empower parents. Do you think the child's ready? If you don't, then we're not ready. But I can help you through it. We have a team here. But nobody, you have the owner's manual on this child. I don't. Nobody knows your child better than you. And I always tell dads, no offense, Dad, but nobody knows a kid like the mom. Maternal instinct is the most powerful instinct on the planet.
So, Kevin, somebody had asked, so a lot of the moms on here have infants. Is there anything that they should be doing
Yes.
as infants?
Yes. 1-800-Jill Rabin. But, you need guidance that way. But there are devices and chew sticks, and you can get mild munchies, and you should do this through a qualified professional.
How early can you do a myo munchie? That's a little like a little retainer that you can use with young babies.
Yeah, and what, I use them. I'm not really crazily endorsing them. I use them mainly as desensitizing devices till I can get an expander in there.
Okay.
But if a child is orally defensive, then using one of these, and there's so many of them, and they all market. They're hard marketers, and they tell you they're the next best thing since sliced bread. Some of them don't perform as advertised, but I've had a good degree of success. But almost every kid that I think would benefit from desensitization are ones that will benefit from expansion when, you know, the family is ready for it.
And so what age should they be bringing young babies to you for you to take a look from the beginning to sort of say like what you might project down
Yeah,
the road?
how about on the way home from the nursery? I mean, you know, but really, in the Academy of Pediatric Dentistry, our policy is we want to see children no later than age 1 and preferably before. And because of what I do, is so much kind of, I don't know, it's not cut and dry pediatric dentistry. I didn't learn, you know, much of this in my residency training. I learned a lot more than most because of my Dr. Noah, Arthur Nowak, just Google him. He's done more for this sort of thing than anybody. And he was my hospital director. But they don't, this isn't part of the curriculum yet. It's starting to become that way. I'm on a task force. I sit on a task force at the American Dental Association that is really bringing this to the forefront in dentistry. So every kid should be seen for their first checkup before age 1. But like I said, if you need to find somebody, and I'll help you find somebody, you don't have to live in Chicago, call us up, or I'll have my office manager and anyone at the front desk, Lila, they will all connect you with me, and I will get on the phone and I'll really help you find somebody that'll
Kevin,
maybe
can you
work.
give me that number so I could provide it for people?
Yes, yeah, it's 312
312.
988 9855. And Jill, you can give out my email address.
Okay.
And again, I'm not looking, you know, I do have people that travel from all over the place. And that isn't my goal here, is that I like to connect. This is the way that we really can spread the word, is if I, you know, get on the phone and a lot of people have heard me speak now, that I will, you know, collaborate and tell them how to assess risk and what the next step. I'll even help them make their first expanders. So, there's a lot like me. I'm part of a consortium called the Endeavor Group. And lots of the pediatric dentists, orthodontists, myofunctional therapists, and family-focused general dentists don't think you got to go to an orthodontist, for crying out loud. But most orthodontists don't have the pediatric skills because it wasn't expected of them in their training. A lot of pediatric dentists have orthodontic growth and development skills, but not really doing orthodontics as young as 2, 3, and 4 years old. A lot of family dentists, general dentists, are better at this. I have a general dentist that's worked with me for 20 years, and she's learned everything I know about pediatric dentistry. And I've been an academic teaching pediatric dentistry my whole career, and I can't teach her anymore. She's teaching me stuff now. She's, you know, she's one of the best pediatric oriented general dentists on the planet. And there's lots of them. There's lots of them.
Which email should I give them? Do you want to give it to me and I'll put it in the
K
chat?
is all lowercase. K is in Kevin, B is a boy, O is in orange, the number 569 @gmail.com.
Perfect.
Yeah, or dentistry for children, dentistry.children @gmail.com will get you to the general mailbox, and every message gets answered.
Dentistry children.
Dentistry.children, all lowercase,
Okay.
@gmail.com.
Got it. Well, if nobody else has any pressing questions, that was amazing. We recorded it, so it'll be available for other people. So I think you're going to get a lot of people reaching out to you, but I think that was great. Thank you so much for sharing that amazing information with everybody so they know what to expect down the road. It was very, very informative, and we thank you so much for taking your time today to share that with us.
That's great. Well, thank you. It's been a huge honor. And look forward to doing more work with you, Jill. Let's
Oh, we definitely. Oh, I'm not done with you. Believe me.
Yeah.
I got lots of ideas.
Likewise. Okay.
Okay, thank you. And anyone who wants to stay on now for the meeting, we can do that.
Thanks, Rachel. Good to meet you. See you guys.
Thank you so much.
Bye.
I'm going to stop share here, and it's all yours.
Thank you.
And then I think stop recording. And then
Yeah, you can stop recording now. Mhm.
Thank you very much. That was excellent.
That was awesome. So whoever's left now, if you want to turn your cameras on, you don't have to if you don't want to, but you can if you'd like.